Great. Well, thank you so much, Chris. Chris has become a great friend and an awesome leader here in our state in many, many regards. So we're lucky to have him here. Sorry, we stole him from Ohio. But I'm so excited to be here. I've been looking forward to this conversation for a long time. And I told my husband that I'm kind of a nerd, but I grew up in Chicago. This is like getting to interview Michael Jordan and Scottie Pippen. This is like, or like Nadal Federer or something. This is like legendary status. These are two of the most impressive leaders in healthcare who have had such a massive impact in so many ways, not just in Ohio, not just in Utah, not just in our country, but globally. So I am so excited and grateful to be here with
Mark, it's time for us to leave.
No. And Toby and I have known each other for a long time. Toby and I met many, many, many years ago when we were on the Williams board, and I learned a lot from him. And Mark and I share a lot of friends in common. So we're so grateful to be here. Let me just start with maybe for both of you, could you just do a quick recap of your careers, all of your successes that you had, and maybe just highlight maybe the thing you're most proud of. So I know it's hard to choose amongst the many championship rings and things that you've done. So.
Well, thank you. It's a pleasure to be here, and thank you very much for the kind introduction. I am a recovering heart surgeon and was CEO of the Cleveland Clinic for 13 years and stepped down about 5 or 6 years ago.
That's just the most modest, ridiculous introduction.
I know.
Can you tell us, Toby, about one thing you're the most proud of that you did at the Cleveland Clinic? And I had the chance several years ago to go to the Cleveland Clinic and tour with him and to see the transformation of that whole city, and also to see how every single person in the Cleveland Clinic he knew by name and said hello to, and all the care that was taken and how you designed the whole place. So tell us a little bit about one of the things you're most proud of.
Well, I think probably the thing that I'm the most proud of, and probably was the most significant, was when I became CEO, I developed a mantra for the Cleveland Clinic of patients first. And I think all of our decisions came from having that as our North Star.
Mark.
All right. Pediatric cardiac critical care, 20 years at the bedside, every fourth night call for 20 years. Served Toby on the executive team at the clinic, was the first chief medical operations officer, and together we integrated this system. Off to Abu Dhabi, founding CEO of Cleveland Clinic Abu Dhabi. 5th CEO in 5 years. If your boss ever tells you, have I got an opportunity for you, you should actually ask a couple of questions probably, but off Mary Carroll and I went, and we were successful there. 6 years as CEO of Intermountain Healthcare. And now have this opportunity to help transform healthcare alongside the GC guys.
I love it. And also doing triathlons, apparently, while doing all of that.
A couple of triathlons over the last 40 years or so.
Amazing, yeah. Amazing. So maybe let's step back. This conference is amazing. You cover so many topics, and we have made so many advancements. There's been so much progress in healthcare in so many ways. But one thing I think a lot about in our state, which I think is an example, is as far as we've come, as many cures as we've had, as all of the improvements, here in our state, between Back Bay and Roxbury is 2 miles and a 23-year difference in life expectancy. That is not something we should be proud of in Massachusetts, but I think that is an example of some of the opportunities that still exist. Maybe tell us a little bit about what are some of the biggest opportunities you think that are out there, and maybe some ideas of how we might go after those.
All right, so when I got to Utah, we actually were able to see some of the same disparities in terms of life expectancy and quality of life that you describe here in Massachusetts. And one of the things that I'm most proud of is that we were able to specifically address them through what was initially the Utah Alliance for the Social Determinants of Health, and then became the National Alliance for the Social Determinants of Health. And we invested in 2 neighborhoods that were very different, 2 different zip codes, and we're able to demonstrate that you could actually begin to close those gaps. I think the thing that I'm really concerned about is that by and large, the business models don't align with the social needs. Mm-hmm. And in the absence of that, I think it becomes vanishingly unlikely that, that significant progress is going to get made.
Yeah, I would say the social determinants are just the same in Cleveland as they are in Boston. There's a 20-year difference within 5 miles in life expectancy in Cleveland. But, and I think that if you look at the social determinants, they really are not things that fall within the general venue of a healthcare provider. Mm-hmm. housing, education, income, food, et cetera. And so I think you're going to have to reach out to have partners that go beyond healthcare. First of all, healthcare providers are not trained, they're not paid, they're not capable of managing these sort of things in a major way. Example of that is, it turns out that the zip code I live in has the highest incidence of lead poisoning in the country.
Wow.
And you know, if that's going to cause your brain development to be retarded, that's going to wind up getting poorer in school, but less job, less pay, but not as good food, not as good housing, the whole thing. So with Cleveland Clinic really came together with United Way in Cleveland, gave $50 million to United Way to begin to deal with the lead paint, et cetera, that is predominant in Cleveland. And so I think you have to bring other agencies in, other partners, whether it be government or local agencies, to begin to address these things, because it's way beyond things that we can do in a major way.
So we disagree a little bit on this one.
I'm sure we will.
Let's bring it.
And I think that if you get the business model right, particularly the payer-provider model, I think it then does become in the health system's best interest to actually keep people well above and beyond, you know, your love for your neighbor. And
Mark, maybe say a little bit, you've mentioned business model a couple times. Tell us what you think is the current business model and what you think is broken
so
and how
very
you would
simply,
change it to make it better.
it's heads and beds is the current business model nationally.
Right.
So we get paid to do things to people. Hopefully they need them, but not always. And I think what we need to do is we need to be paid to actually keep people out of the hospital in the least restrictive, least expensive, most effective environment possible. And probably the most cogent example is a kid I took care of in the pediatric ICU who came in with repeated status asthmaticus. And intubated, sick kid, went to the floor, went home and had proven dust mite allergy, and went home repeatedly with the admonition to have, you know, dust abatement, mite abatement in their house. Couldn't afford it, right?
Yeah.
So for lack of a couple $100 of work around the house, we would do, you know, $10,000, $15,000, $20,000
It's crazy.
In the emergency department and in the ICU.
Yeah.
And it makes sense if you're in a payer-provider model to go ahead and just pay for that to happen for the kid. And I think that that's the way we change our system.
Yeah. Do you disagree with that, Toby?
No, I don't disagree with that. I think that we're talking about the level of which we can do that. I mean, this includes education, food, housing, so many things that are beyond our economic capabilities.
Fair enough.
Yeah. I'm curious, so and on the business model front, so many hospitals are, you know, during the pandemic, they were heroes. They did not nobody got to work remotely. We've gotten through that, but many hospitals are still struggling with workforce shortages, with inflation, with you know, all kinds of pressures, and also, you know, kind of being vilified. The days of, you know, everyone thanking their doctor have maybe gone away. How do you think about what's key for hospitals in this payer-provider business model?
Go ahead.
Well, I think there's a number of issues to unpack there.
Yeah.
So the pandemic was an incredible experience to lead through. And as tragic as it was, it also was unbelievably exciting and invigorating, the opportunity to collaborate with your competitors and to simply do the right thing every day. Probably my best accomplishment as a CEO was to be able to call my board chair and I said, look, no one's getting laid off, no one's having their salary cut except for my team. Everyone's getting all their benefits, and that's how we're going to exercise our balance sheet through the pandemic. And that's exactly what we did. I'd say that the pandemic demonstrated that our health system is actually a national security issue, and the brittleness of it puts us all at risk. I think that a payer-provider model that aligns incentives and that gives that entity the first premium dollar, and with that you can be endlessly creative use of technology, use of AI, use of alternative care sites. I think that's actually how you make a difference.
Interesting.
Yeah, I look at it a little bit about physician heal thyself. We are very expensive in healthcare in the United States. And 60% of the cost of hospitals is people. It turns out that the administrative cost of hospitals over the last 50 years has increased 3,000%.
Wow.
And just in the numbers. And so we have got to figure out how we manage to reduce the cost of healthcare, and particularly things like the 3,500 people we have in revenue cycle at the Cleveland Clinic, the 1,000 people that we have in call centers. And this is one of the places that I think that AI is going to come in and help us in a major way. And I look at that as technology coming in and helping us with the workforce shortage, helping us with reduce the cost substantially. You see things like, think about on the floor, a nurse going around and every 4 hours getting vital signs and waking up in the middle of the night to get your blood pressure. There's now technology that you can stick on somebody and gives you continuous readouts of all your vital signs. Think about the work that reduces. You're starting to see robotic things coming along. The other day I saw a robot that cleans the bathrooms. Another robot that goes in and drills teeth. These are in their infancy right now, but it's going to reduce the work and all of the people that we have, and hopefully make people more efficient across the entire system. So I think there's so much cost that we can take out of healthcare if we embrace it. The problem is that everybody now is looking at a way not to increase costs, but in fact get the technology in that cuts costs. The long-term approach is going to be difficult to integrate because hospitals are financially strapped at the moment and unwilling to take on new initiatives.
This is a really important point. We talk about this a lot in our state, and we're lucky. We have amazing hospitals like Mass General Brigham and like Bethesda Lahey Health and many others. But and we have incredible life sciences leadership. So we are the global leader in life sciences. But we're under so much pressure, and you can have the best drug discoveries in the world, but if you don't have people to administer and prescribe them, it doesn't really work. I'm curious what your view is on AI, Mark, because we have been looking at AI in our state. The governor was here yesterday. I just saw her right before this, and we've kicked off a statewide AI task force, and are looking at ways that we can apply AI. I think Toby's right. There are a lot of interesting potential applications. There's also a lot of fear and a lot of concern, and also a lot of inability to actually fund some of these experiments and technologies.
Yep.
I'm curious, Mark, what your observations are.
So you can either build a house with a hammer or hit somebody over the head with a hammer. AI is a tool. It's like a hammer. I think that we have to manage the risk. By the way, I actually agree with everything Toby said on that front. We're at an inflection point in the industry where all the headwinds are so great that we actually have to do something different, and I think AI is the logical place to do that. And by the way, you guys do have great hospitals here in Massachusetts, and there are great hospitals elsewhere, but if we look at when the Crossing the Quality Divide was published by IHI, I think that we were losing about 100,000 Americans a year to mistakes in our hospitals. Now it's 200,000 people a year. So we're still screwing up right and left, and anything we can do to actually help things be safer, I think I'd be a real fan of.
Let me just add, I think, one other concern that I have, and that's the explosion in knowledge. The total amount of knowledge in healthcare now doubles every 73 days. There's 1.8 million medical articles written a year. Nobody can possibly keep up with that. And as a result of that, you see that what's going on is the time between a proven technology and its standard of care is now 13 years. And that is because if you don't learn it in your residency, that's the half-life of a doctor. If you don't learn it in your residency or before, you're probably not going to practice it. So, you stop and think, how often are you not getting the latest and greatest in terms of your care? And by bringing the knowledge in a usable form to more and more people, it should shorten that time from 1 year from 13 years out, and hopefully it will. I recently was at OpenAI about 2 weeks ago and saw version 5.0 of chat. Wow. It's getting better and better all the time. And in fact, it may actually be a bigger change in underdeveloped countries than it is in the United States, simply because the need is so much greater and it'll be embraced faster than it will be here.
What are some of the ways, to your point, so the technology is getting more powerful and it is a hammer that we want to use to build a house for good. How would you help hospitals and also doctors and nurses adopt it and accelerate the adoption of it in ways that are helpful? Because there are all the reasons why it's hard. What are some ideas that we could have to accelerate adoption?
I don't think we need to push AI on folks because they're using it already. And most of the clinicians are, if it's not available through their hospital networks, are using it on their phones. So
interesting.
The question is, how do you actually formalize that and make it part of the workflow? Because I think that's the huge problem with most digital transformation is people treat it like a standalone, and really it just needs to be integrated in how we take care of patients. So our son, our oldest, is a MFM fellow, maternal fetal medicine fellow, and we were visiting him last weekend. He was telling me about this fetus that he scanned that had bilateral club feet but no other obvious anomalies. And I said, okay, you did the consult on this kid. What if we go on one of the large language models and put in the information, and let's see what your differential diagnosis was versus... And it was like 90% great, but the AI model was 10% better than his. He said, I didn't think of that one.
Wow.
And I think it just needs to become part of how we, and by the way, it took like a minute and a half to put it in.
But I think that what we're going to see, though, is across where the major savings are going to be for healthcare delivery, it's going to come from the administrative side of things.
One hopes.
We hope,
Yeah.
but that's going to come from the top down, and it's going to take leadership to do it. And if the CEO doesn't embrace this and drive it, it's not going to happen. And I'm concerned that that it has not been embraced by a lot of CEOs across the country of hospital systems to begin to put a governance system in place and a plan to embrace this, because it really is, to me, a salvation for the cost and the workforce.
So Toby, I'm curious, we both led really great not-for-profit systems. I worry constantly that not-for-profit healthcare is not nearly hungry enough. I don't mean financially hungry enough. I mean hungry enough to get better, to move, to improve, to reorganize, to streamline. And I'm not talking about being not careful with patients. I'm talking about just improving. And how do we change that?
I totally agree. And you stop and think about this is leadership in healthcare. And if you stop and think of doctors, think about our training. We got into medical schools because we got through organic chemistry because we couldn't memorize. Then we memorized for 4 more years in medical school. And then we did what we were told for 5 years after that, which essentially selects out and trains out all the initiatives that you might have. And as a result, healthcare has been so slow. And my biggest regret as CEO was I didn't move fast enough.
And you actually moved plenty fast compared to a lot of people. I mean, it's actually...
So for some of us who tried to follow you, you moved pretty
yes.
you moved pretty
well,
fast.
It is an interesting question because, and it's a sensitive one here in Massachusetts, because we had a for-profit hospital, which has not really been a very good story for us and has been very difficult. So figuring out the right model, because there are pros and cons, and obviously on the nonprofit side, how do you increase the pace? I'm not sure for-profit is the right answer, you know.
No,
either.
I'm not sure necessarily just for-profit is the answer, but I think that that's why I'm so concerned about leadership. Leadership, unfortunately, has been selected in many cases not because of leadership characteristics, but because they bubble to the top on the basis of their CEOs, their CVs, or their resumes, and not because of leadership, and it's a completely different capability. Doctors are trained essentially to be technicians, not to be leaders.
I would agree with that. Without touching the Massachusetts
Which
issue,
is an egregious case.
No,
I
let's
would
not.
not paint all for-profit hospitals. There are some very good for-profit hospitals.
I was
so
just
this is
gonna
an
say
egregious,
that tax
egregious
status
case.
doesn't necessarily.
Yes, I agree with that.
And I think one can find good and bad examples.
I agree with that. Yes, no, I agree. I mean, yeah, go ahead, Mark.
So I think Toby really is onto this critical issue of, why are people doing what they, why are they living these leadership careers but not actually truly leading? Mm-hmm. And it feels like such a wasted opportunity to be given the privilege to be in the seat and then to not lean hard into every opportunity and be willing to make a mistake, look like an idiot every once in a while, mm-hmm. but also to make a big difference in other people's lives. And I find that disconnect really, really difficult. It's actually one of the reasons why I like working with the folks at General Catalyst so well is they really put their money where their mouth is, and they do what they do for social good, and makes me proud to work. That's leadership.
Mm-hmm. The other thing is, I don't think you have to be afraid to make mistakes. God knows I made enough mistakes, except they're seldom fatal, except maybe in the operating room as a cardiac surgeon. But the mistakes in leadership are, they're all remedial.
I think that you taught me to say, "I'm wrong, I'm sorry, I love you." I think that was something that.
No, that's for your domestic life.
I love that. I love that. I want to switch a little bit, and I'm curious. So you have worked in multiple states and multiple countries. I'm now in state government after having a long career in the private sector. Do you have advice for how the government, whether it's state or federal government, should help our healthcare system? What are things that we can do that would be helpful? Are there things that we do that is not helpful, is actually, negative?
Well, we're probably the most regulated industry other than maybe the airlines. And the regulation is almost stifling in many cases, and what it will allow you to do and not do. I think, we're going to have to figure, first of all, I think the regulation is tough. The second thing is, I think ultimately we have to get everybody in this country covered. And to have people who are not covered in one way or not for their health care is something that is an embarrassment, frankly. We need to get past that. And government, that's a primer for government, I think. Mm-hmm.
So I really admire you for serving the public. It's not easy. From watching from very close up, it's not easy. I think the mistake we're making, maybe I lived in a red state for a really long time now. We shouldn't be waiting for the government to solve our problems. Mm-hmm. By definition, governmental intervention is a relatively blunt-edged instrument. Mm-hmm. I think that health system CEOs, people who are payer providers, the big payers have immense amount of latitude to actually use creativity mm-hmm. and leadership to actually drive the ball forward mm-hmm. and maybe have the government be in great support. Mm-hmm. And I think we abdicate that responsibility all too easily and then act as victims. You can't be a leader and a victim, right? And I think we act like victims too often.
Well, I think this is what inspires us here in Massachusetts. I think we have had some real moments where we've led, not just for our state, but for the country. So Romney Care becoming Obamacare, our COVID vaccination and testing protocols, then going to the CDC. And at our best, we work across ecosystems. So public-private partnerships across our medical schools, our hospitals, our private sector, our big pharma companies, our startups, all of our nonprofits, our towns. When we work together, I think we can really solve some things. And that's why the governor, I think, spoke yesterday about our $1 billion in our economic development bill to kind of think about this next chapter and how do we kind of work together to solve some of these big problems and to lead and not be victims. We just have a little bit of time left. I'm curious, so I talk a lot or think a lot about healthcare in America. It's a big part of our GDP, growing faster than a lot of the rest of the economy. It is ultimately you're dealing with people's lives. It's people's health, it's people's families. And in our state, it's half of our state budget. And there's tons of room for improvement and innovation. I'm curious, if you could have a blank slate, what are the one or two things that you would really do to try to fundamentally change healthcare in this country? And I think you've mentioned a couple of them already, but if you had to, and you have a room full of leaders here who are off, you're trying to fix this. And so what advice would you give them? What are the one or two things that you'd really try to focus on?
Well, I focused on partnerships. I think too often, let's take technology, for example. I think too often we think we want to do everything ourselves. And I think a good example is everybody tried to do their own electronic medical record, and after 15 or 20 years of trying that, they decided they're going to have an outside vendor. And we don't make our own heart valves, and we don't need to have everybody do everything internally, and we need to partner. And I think we need to partner with businesses, and I think we need to partner with other organizations that are helping the welfare of our communities.
I'm going to hit it from two ends of the spectrum.
Please.
Okay, so the first is there's no other industry that allows you to see another person's humanity as clearly as healthcare. Mm-hmm. It's an incredible privilege. And I think really doubling down on how we train the people who provide healthcare to how actually people are trained to receive it provides us with an opportunity to depoliticize our social woes. So it doesn't matter how you feel about the Second Amendment, nobody wants their kid to shoot themselves in the head. Mm-hmm. Nobody does. Mm-hmm. And I think the opportunity to actually begin to make clinical some of these social problems and find common ground is an enormous, enormous opportunity. On the other end of the spectrum, the advances in things like gene therapy, cellular therapies, immunotherapies, et cetera, really have the possibility to bend the curve of how people look at chronic conditions. Mm-hmm. And we need to figure out a different way of paying for them because it doesn't work for the insurance companies.
Yep.
And I believe that we can both spur innovation, change the public health, and have it be economically sustainable. So see our humanity, figure out how to pay for the fancy stuff.
I love it. We actually have a couple minutes left. I'm curious, this is going to be a bonus round. So I love that you two have disagreed on some things, but also you've agreed on some things, and clearly on this topic of leadership and taking risks and making mistakes and being innovative. What set you two up? How did you get to where you are? Because you've both been trained in the same systems of memorization. And a small confession to make, I was pre-med because I'm a child of immigrants, and I got into medical school. And I went and did my summer at Mount Sinai to prepare for medical school. And I remember sitting in the classroom for like 10 hours memorizing things and then doing rounds and seeing how miserable the doctors were. And I was like, I don't know if this is for me. So I didn't go to medical school, but you both did, and you were raised in the system. What changed for you? And how do we get more people in the healthcare space to be like the both of you?
Well, I think, first of all, we have to change the leadership in healthcare has to realize that we have to be more innovative. We have to listen to more voices. We have to listen to accept more ideas. And that is going to change the atmosphere in which we deal. But we have to also take all the grunt work away from docs as much as we can. the grunt work is just burning docs out. We didn't go to medical school to become typists. And I think just look at the ambient listening, that's going to be go from a nice to have to a have to have. And that's probably the most, from the clinical standpoint, that's going to be the fastest accepted technology that hits the clinical arena.
Yes to what Toby says. I think it goes back to that locus of control issue about whether you're a victim or a leader. And so I think it's Seligman from University of Pennsylvania wrote about learned helplessness. And if you don't have optionality, you become depressed and you give up, right? We need to actually listen to the people who are doing the jobs. And we as leaders, it's our obligation to actually clear the way for them to be effective and allow them to have agency. With agency, they can do anything. And they should have love for their job. And I think that if we do our jobs right, then our kids and grandkids will want to go into the same profession that we've gone into. We failed at that for right now, but I actually firmly believe we can change that.
Well, on that note, I would just say we just need more leaders like Mark and like Toby. We're very grateful. So thank you both so much.
Thank you.